afternoon. Welcome to our July Clinical Research Lunch and Learn at Children's and Women's. Really excited for this afternoon's presentation on knowledge mobilization. Just want to start by gratefully acknowledging the lands with which we're coming from today of the Coast Salish people, specifically the Musqueam, Squamish, and Tsleil-Waututh Nations. Very grateful for the opportunity to live, work, and learn on these sacred lands. I'd like to start by introducing our three speakers today. So joining us today, we have Kaku Lema, Nicole Prestley, and Roisin Delaney. So Kaku is the Knowledge and Mobilization Manager for the Sexual Health and Genitopelvic Pain Knowledge Empowerment Hub, also known as SHAPE. SHAPE is a pan-Canadian initiative dedicated to addressing barriers to evidence-based information and care for sexual difficulties and genitopelvic pain affecting both women and gender diverse people. In this role, Kaku facilitates the exchange and co-creation of knowledge among researchers, healthcare providers, and patients, working to ensure that information on these conditions is accessible, inclusive, and impactful. And with a background in stakeholder engagement and project management, Kaku is committed to bridging research and practice to advance sexual health equity and support patient-centered care across Canada. Next, I'll introduce Nicole Prestley, who I'm sure if you've been joining the Lunch and Learns, everyone should know, but Nicole is the Manager of Research and Knowledge Translation at the WHRI. Nicole has worked in healthcare research since 2006, starting out at Arthritis Research Canada. Nicole is dedicated to accelerating the access to and use of research for patient, public health systems, for patient, public health system provider community, and other knowledge user audiences. Nicole has formal training from the Knowledge Translation Program at St. Michael's Hospital under Dr. Sharon Strauss, and also the University of Toronto and Sick Kids Hospital under Melanie Barwick. And lastly, we have Roisin Delaney. Roisin is the Knowledge Mobilization Coordinator for the UBC Reproductive Infectious Disease Program. Specializing in community health, Roisin's academic background is in psychology and global health. Her previous work has focused on the design and implementation of community-based health initiatives and the development of knowledge-sharing tools to promote maternal-child health at the local level. Currently, Roisin is focused on driving the knowledge mobilization deliverables of a pan-Canadian syphilis in pregnancy and congenital syphilis project. Roisin is passionate about health promotion, access to health education, and women's empowerment. Thank you so much, and we'll turn it over to you to get started.
Thanks so much, Shanley. We very much appreciate being here today, and we're excited that you all showed up to hear our presentation from planning to practice knowledge mobilization for this C&W Research Lunch and Learn. And thank you for starting us off and acknowledging the lands that we're joining from. And I just want to point out the three kind of foundational reports that can guide a lot of our work in reconciliation: the Truth and Reconciliation Commission of Canada, the In Plain Sight report, and the Reclaiming Power and Place. And many of these reports have calls for justice, calls for action that we can incorporate into both our personal and professional lives. Now, because we are talking about knowledge today, I wanted to draw our attention to the Reclaiming Power and Place report and the Call for Justice, 15.2, which really does kind of reinforce the importance of decolonizing our practices and learning and celebrating Indigenous peoples' history, cultures, pride, and diversity. And when I started out in the knowledge translation field and discipline, knowledge was really synonymous with terms like high quality evidence and the evidence pyramid and randomized control trials and meta-analyses. And now as work towards meaningfully decolonizing many of our systems, including health research systems, I have a broader understanding and continue to try and learn about different forms of knowledge. And so I really just want to point out a great resource that was created in 2005 called Sacred Ways of Life, Traditional Knowledge, which highlights different traditional and traditional forms of knowledge. It can be in the form of storytelling, traditions, ideologies, arts, and other forms of knowledge. And I'm happy to share all the resources from what we present today. Just because we are, there's 3 presenters today, and we're going to move pretty quickly through our presentations. But the format is such that I'll be your grounding exercise in KT planning and talk you through different concepts of KT planning. And really, the heavy lifters here are Kaku and Roisin, my KT professionals that I have the pleasure of working alongside. And they'll give you some excellent case examples, and I'm sure you'll all be experts in congenital syphilis and genitopelvic pain and knowledge translation planning at the end of this. So to kick things off, we know that there's over 120 different ways to describe knowledge translation or knowledge mobilization. And these 3 definitions, ones I lean on to just kind of point out that different definitions have nuances to them, and they're all important. Knowledge translation, which used to be the favorite at CIHR, but now they've moved to knowledge mobilization, is about synthesis, dissemination, exchange, and ethically sound application of knowledge. And I like that they call out improving the health of Canadians, because this really does reinforce our accountability as researchers to improve the health of Canadians. Knowledge exchange. What I really enjoy about the knowledge exchange definition is that it talks about the environment needed to do knowledge translation. And I think acknowledging that sometimes we encounter barriers to doing our KT and KM work. And so advocating for a culture of knowledge translation is just as important as practicing KT itself. Last is knowledge mobilization, and this really names the importance of reciprocity in our knowledge mobilization work, and it also acknowledges that knowledge can be created both within and outside of academic spaces. And there's 2 different types of knowledge mobilization: end of grant and integrated. These definitions stand on their own quite well, but the diagram on the right kind of showcases where end of grant KT tends to happen in the green highlighted areas. And so end of grant KT is something we write into our grant applications. It's required in many cases, and there's nothing wrong with it. It's necessary to be intentional about where we're sharing our findings. Integrated KT, though, is really the one that we recommend folks try to work with, and that means thinking about who might use your research, thinking about who might benefit from your research or champion your research, and involving them in every stage of the research process, from ideation all the way to interpretation of results. Now, today I'm going to do a quick overview of where you might start in terms of your KT planning. And while there are a variety of KT planning tools, all with strengths and limitations, the one that I've selected today is from the Public Health Agency of Canada, and this is called their KT Planning Primer. There's sort of 5 aspects to the planning primer. The first is who will you reach? Why? Why are you doing this? Or what are your KT objectives? What? And this is about the main messages. What do you want people to know and take away from your KT work? The how, this is the strategies, the knowledge products that you may create that enable you to reach those knowledge users or target audience members. And then the impact. So what does success look like? So finding your audience is a critical first step. In the KT, KM world, you'll see this also. Knowledge users are usually synonymous with research users, and this can really be used to describe people like healthcare providers, the general public, people with lived experience or patient partners, organizational decision makers. And it's worth noting that even though these are kind of more general labels that we use as knowledge users, there's more kind of subcategories within it. And so your research project and your knowledge users may be a specific practitioner type. So you may be looking for nursing collaborators, or you may be looking for a specific researcher type, like a basic scientist. The other really important components of the WHO is thinking about your target audiences and what needs they may have. Is it a general public audience? Have you thought about accessibility in your KT work? Have you thought about gender inclusive language and read our Beyond the Binary guide? Have you thought about health literacy levels in the messaging that you're providing? The other piece is around the messenger, and the messenger we know really does matter. Some audiences respond really well to a peer from their own community. Other folks really want to see messengers who are perceived as credible and trusted. So it's important to be really intentional and understand those audience needs and characteristics. Then we move into the why. Ooh, apologies, folks. My screen has frozen. There we go. Okay. The why is about your KT objectives. So this is why are you doing what you plan to do? And now your KT objectives are going to be very distinct from your research objectives, but they are connected. This is really what you want your impact to look like and be. And some ways of articulating your KT objectives are to think about whether you're generating awareness, interest, or use in a practice change, or whether your goal is to gain a new perspective or form a new partnership or collaboration. Objectives can be short-term, long-term, and as you're wrapping up a research project, you may find you have a multitude of KT objectives. We understand that it's not feasible to address every single one of them. What I typically recommend is for teams to keep a parking lot of potential KT objectives so that you can be opportunistic about addressing them. It may be that an opportunity presents itself that requires no resources for you to address that objective, whereas in other cases, you may want to use that objective to write a grant application for a planning and dissemination competition. So, what are your main messages? This, to start, you want to think about what it is that you're sharing. Are you sharing data? Are you sharing findings? Are you sharing processes or recommendations? Or are you sharing ideas for future research? All of these are important, and all of these need to be articulated in your KT plan. This helps inform your main message, which really does anchor your KT planning. What you want to think about is what you want people to know about that data, the findings, the processes, the ideas, and what it is you want them to do with it. So your main messages should be clear and actionable. Of note, you can have more than one main message. And because we have different audience types, it's completely appropriate to tailor the language in each of your main messages to different knowledge user types and audiences. And what I often suggest to folks is to create a table with different rows and have that main message. And the tailored version of it for each one. Just please do make sure that you're preserving the integrity of that message and we don't tailor so much that we actually lose the integrity of the message we're sending. So now we get to the how, and this is really where our integrated KT approaches are critical. When you have knowledge users on your team, your first task is asking them, how should we get the word out? What products should we create to accompany our main messages? And the one thing I wanted to just flag here is that we know unequivocally that almost across knowledge user groups, visuals are really, really important in our KT planning activities. So data visualization, infographics, process maps, and artwork have all, we've seen evidence to support KT strategies across clinicians, the public, and other folks. The good news is that in addition to asking your partners and your knowledge users, there is evolving evidence around KT strategies for different knowledge users. So these three resources that I've highlighted here, both the Alberta Health Services resource and our locally created resource from the Evidence Centre, which is stewarded by our Children's and Women's Library Services folks. They have knowledge user types and levels of evidence for each of the KT strategies that you may be looking at. Whereas the National Collaborating Center for Methods and Tools, they have an excellent, they have two repositories that's about evidence-informed decision-making as well as organizational change. So if you're looking for more health systems change, health policy, they have some excellent templates that you can work from. Now, the other thing that I'd suggest is also ask around in your existing networks. One of our biggest principles in KT is to meet people where they're at. And sometimes someone who's on your team may have access to a newsletter where you can just insert your content. People already read that newsletter, and it delivers the message without creating a new pathway for them to hear about it. Now, almost last but not least is impact. And, you know, this is a question I often get from teams is how do I measure success? One of the best ways to think about this is in the KT planning phase when you're thinking about your objectives, think about what success would look like. And, you know, I'm mindful that when there's social media campaigns or websites that you're tracking metrics, there's an abundance of numbers you can pull from. It's reasonable to choose some metrics that you want to say, these are the metrics of success we're going to monitor. And because in the KT world, we're not resource. It's not, there isn't an abundance of resources. So we have to be reasonable and practical in our evaluation tactics as well. The other piece I wanted to just mention, while KT and evaluation are great, or evaluation is great to do at the end of a project, monitoring and doing evaluation throughout is actually a really great way to spare resources that may not actually be reaching your target population. And so something that we often do with teams is request that they provide updates on their metrics at different COI meetings or team meetings, because if we're not reaching that audience, you can reallocate someone's time and resources to a KT strategy that actually is. And before I pass the mic over to Kaku, I just wanted to just mention the importance of equity, justice, and human-centered approaches into this work, which with both Roisin and Kaku will touch on. IKT, I've mentioned. I think most folks here know about patient-oriented research and being reciprocal and intentional with our partnerships. The other two I wanted to mention is about trauma-informed care. So really recognizing that a lot of our partners are coming into this space having experienced harm within the health system, and it's on us to really ensure we're not reharming people and try to ensure safety as much as possible. And then the last is justice-oriented approaches, which I'd really encourage folks to watch the CW Lunch and Learn that was done by Oakley on intersectionality, which really highlights the how we incorporate that into our work. Over to you, Kaku.
Yeah, thanks, Nicole. So now I'll walk us through some of the work we're doing with the Shape Hub and provide some concrete examples of what knowledge mobilization looks like in practice. Next, please. Okay. So before we dive in, I want to give some quick context and break down some key terms. Sexual dysfunction refers to problems with sexual desire, arousal, orgasm, or sexual pleasure. So these are common, more common than people actually think, and they can really affect a person's quality of life. Sexual dysfunction can result from physical causes, emotional factors, or even things happening in a person's relationship at the time. And then genital pelvic pain occurs when someone has ongoing or recurring pain with vaginal penetration, fear or anxiety around penetration, or even pelvic floor muscles tightening up when penetration is involved. Next, please. Looking at how common these issues are, about 1 in 3 women report distressing symptoms of sexual dysfunction, and then about 1 in 5 live with chronic genital pelvic pain. And then beyond those numbers, we know there's very little data on how these conditions affect trans women, two-spirit people, gender diverse people, and racialized communities. So their experiences are often missing from research. So the graphic on the right shows another layer. So even when people do seek help, only 1 in 4 actually, attempts to seek care, or even they end up facing obstacles in getting support. So these conditions are most common, but often go unspoken or unaddressed. And on top of that, there are gaps in access to not only care, but evidence-based information on these conditions, specifically looking at women and gender diverse people. Next, please. So this is where SHAPE comes in. So SHAPE stands for the Sexual Health and Genital Pelvic Pain Knowledge Empowerment Hub, and it was created in response to some of these gaps in knowledge and care for sexual dysfunction, specifically looking at women and gender diverse people. So SHAPE is a 4-year project funded by the Canadian Institutes of Health Research, and it launched back in October of 2023. The hub brings together a diverse group of clinicians, researchers, policy experts, as well as patient partners. So the idea is that by working together, we can share and co-create evidence-based knowledge on sexual dysfunction, and do it in a way that actually reaches the people who need it most. So the collage on the right shows our co-hub members, and at the top, you have our principal investigator, Dr. Lori Brotto, our NGO partner, Dr. McKay, and then our physician lead, Dr. Melanie Altus, and they form the tripartite leadership team. Next, please. So Nicole had talked about having the why behind your knowledge mobilization work. So for us, these are gaps that exist, and then SHAPE is working towards closing those gaps. So first off, very few providers have training in sexual dysfunction and genital pelvic pain. We want to change that so that providers can have knowledge and skills to better recognize and then manage or treat these conditions. Secondly, symptoms are often dismissed or misdiagnosed, and then there's stigma around this topic area. So our goal is to see these conditions acknowledged and taken seriously, both within these within the general public as well as in healthcare settings. So it currently takes an average of 3 to 5 years to get a diagnosis when someone has these conditions. And we want more general practitioners to be equipped with the right tools so people can get care sooner. And then finally, many patients don't have information they need to advocate for themselves, or even to navigate how to seek help when they have one of these conditions. So we aim to ensure that women and gender diverse people are informed and they feel confident speaking up about their care. Next slide, please. So Nicole had touched a bit about different knowledge user types and partners. And this slide kind of summarizes the partners and knowledge users within SHAPE. So SHAPE's work is patient-oriented, and that means our work is done with patients and not just about them. So we work side by side with patients who have lived experiences of sexual dysfunction, and together we co-produce. So whether that's knowledge products or research, we work together ensuring that we directly address patient needs as well as needs of healthcare providers who get patients with sexual dysfunction in their clinics. So at the center of our work, we have 6 core patient partners. We also have 3 Indigenous scholars in the hub. We have about 7 researchers, and that's a mix of early career researchers as well as senior researchers. We also have 8 healthcare providers who specialize in sexual dysfunction. We have more than 40 trainees in various universities across Canada. So these are postdocs, residents, and various graduate students who are doing research in sexual health. We have 3 NGO partners, BC Women's Health Foundations. We have Options for Sexual Health, and then we have CCAN. And we also have knowledge translation and policy experts as part of the hub. And all these voices kind of shape the work we do. Next slide, please. So what do we want to share with our knowledge users? So I'll walk us through the first example. In our case, we want to share research findings on women's sexual dysfunction in the form of practical kind of evidence-based tools for both patients and healthcare providers. And what do we want them to know? So for patients, we want them to recognize symptoms of sexual dysfunction and know when and how to seek care. For healthcare providers, we want them to have clear evidence-based ways to assess, diagnose, and manage these conditions. So the process is characterized by co-production, where you have researchers, patient partners, and healthcare providers in SHAPE working together to produce the knowledge products that we need to share. The flowchart on the right kind of shows or summarizes how that process looks like in the background. So from inception, where we identify a condition, so for example, you can have a condition like low sexual desire, then researchers kind of pool together evidence-based information on that condition. Patient partners come in, contribute, providing their perspective to that draft, and then you have healthcare providers then also come in at that stage to make sure it's practical for use in clinical settings, both for patients and providers. And then we move on to having the message or the material translated to French. And then we have all parties signing off on the final message or the content, the material. Next slide, please. So the next step is figuring out what format works best for different types of content or the message. For patients, some of the information is laid out in the form of fact sheets and information sheets with clear steps to recognize symptoms and know when and how to seek care. So we use infographics so that key points are kind of easy to see at a glance. We have short videos to share content like patient stories and testimonials, as that kind of makes the message more impactful. So just figuring out what format works best for what type of message you're trying to share. And then we have for healthcare providers, some of the information is better shared in the format of primary care toolkits with assessment and management guidelines. So you have examples like the vulvodynia toolkit. If we're sharing findings from new research, these are kind of laid out in summary reports that highlight key evidence and best practices for healthcare providers. Some of the information is best shared through training webinars to kind of help build clinical skills and confidence in managing these conditions. And the images up on this slide kind of just show the formats that we outline, different and various information in SHAPE. Next slide, please. So here we're talking about delivery. So how do we actually get these resources or our message in the hands of knowledge users? So in our case, we will host everything in one dedicated section on the CCAN website. And CCAN stands for Sex Information and Education Council of Canada. And they are one of our 3 NGO partners. So users will be able to filter by user type. So if you're a patient or you're a provider, if you want the content in English or in French, and if you want content on just a particular condition, say endometriosis, you'll be able to do that. The portal is currently under development and will officially launch September of this year. And we will be using social media posts to drive the general public to this portal. We'll also be sending out newsletter to share information about the portal with different research communities, as well as clinical practices across Canada. And then we'll also be running training sessions and webinars for healthcare providers to kind of help build their skills, as well as access different resources on the portal. So the screenshot on the right shows you what the portal kind of currently looks like as it's being put together and how these resources will be laid out. Next slide, please. Other type of knowledge or information or the message is best shared in the format of clinical training and on sexual dysfunction for healthcare providers. So we're working with NGO partners like Options for Sexual Health, and they already have a large network of providers. So we provide training that is designed to help providers easily recognize different presentation of sexual dysfunction and how to apply evidence-based approaches to managing these conditions. So on the right, you can kind of see a snapshot from one of these sessions being led by Dr. Brotto, our principal investigator, and Dr. Altus, who is our physician lead. Next, please. Okay, so that was the first example. Now I'll walk us through a second example. PSSD, or post-SSRI sexual dysfunction, is a sexual dysfunction that arises in some users of SSRIs or SNRIs, antidepressants. For this condition, there's very little research that has been done. And so we launched a community-driven research priority setting project. So we started off by identifying the gap. In our case, there's very little research on this condition, which means lack of evidence to inform clinical practice. Next, we engage stakeholders by forming an advisory group, which comprised of patients with lived experience of PSSD, and then healthcare providers who see PSSD patients in their practice. And then together, they co-developed the research priority setting study. So developing the survey itself. And then our role was to facilitate that. So facilitate meetings where this group kind of came together, met, and worked towards developing the study. And our role is to make sure that everybody's voice is heard. And then the patient partners kind of took lead on sharing the survey widely across different PSSD communities across Canada. And then the group kind of came together again once the survey had closed to organize the priorities that emerged from the survey. So they kind of worked together to kind of group similar ideas and then ranking the priorities together as a team. And from that, we launched targeted research funding using the identified priorities to kind of shape calls for proposal, so research projects, and then we'll be awarding grants to projects to address these priorities. And then the grants launched back in May of this year, and the group will kind of come together again once those projects come to an end to kind of share and apply the findings from these research projects. So what message do we want knowledge users to get from this sub-project within SHAPE? For the PSSD community members, it's letting them know that their voices can directly shape the future of research. For healthcare providers, these findings help improve clinical understanding and care for people living with PSSD. And that graphic just kind of summarizes at a very high level what the process looked like. Next, please. And then looking at the format for delivering the different messages around the research priority setting project. So for patients, we created a survey that was written in plain language, easy to understand, easy to navigate, and it asked them about their experiences living with PSSD and their views on what research priorities should be. And you can see up on the slide some of the questions that were in that survey. And then for healthcare providers, researchers, we pull all those findings from that study into a short summary report, and it's meant to guide future research. And the image on the furthest right shows the cover of that report, which is available for anyone to download and use on the Shape Hub page. Next, please. And then looking at how we went about reaching a broader audience to share information about the research grant call that emerged from the survey. So we promoted these grants by giving talks at key events and forums where attendees were mainly researchers and healthcare providers in the sexual health field. We work directly with PSSD communities and NGO partners, so leveraging their platforms to reach a wider audience. And then we use newsletters and created a dedicated section on the SHAPE website to share information about the grants. And then on the right, you can kind of see examples of social media posts that were put up by our NGO partners. You can kind of see a snapshot of the newsletters that were going out to announce the grants. And even photos from some of the events where we gave talks about the grants. So the goal was to reach trainees and researchers who can take on these projects on the identified priority areas. Next, please. Nicole had touched on about impact. So when we talk about impact, one of the key things we look at is how many people we've reached, engaged with, and more importantly, worked alongside with to meet our objectives and what came out of that engagement. So we track numbers like how many providers attended our trainings, what did they share in the evaluation forms that they completed after the different trainings, what does that look like for designing future trainings. We also look at how many patients and community members take part in co-producing the research studies, and also some of the knowledge products that will go on the CCAN website. And for each objective, we check what we set out to do at the start of the year, where we've made progress at the end of the year, and how we plan for next year. And all this information kind of comes together in an annual impact report. And that report goes back to our patient partner communities. It goes back to our healthcare providers, the trainees, and our NGO partners. And it's important because it shows each partner exactly what their involvement has achieved, their reach, the engagement, and the outcomes, so that they can see the difference that they help make towards reaching our main objective. Next, please. And finally, some of the lessons we've learned along the way. One, I can't stress enough the importance of centering lived experience. Patient partners should not be, brought in after decisions are made. They should be brought in at the very start to kind of actively shape the work right from the get-go. And then secondly, I would say prioritize usability. So any knowledge products that you share needs to work for that particular user that it is intended for. So looking out for things like plain language, easy access, different ways that people absorb information. And then also be prepared for mistakes. They will happen with any work that we do. Just be open about them, own them, and then adjust your approach. I think it's also crucial to remember that community-based work takes time. And so rushing sometimes undermines trust. So being patient, being flexible, and adjusting your timeline, I feel is super important. And then co-creation can kind of be messy. It's really messy, but completely worth it. The process is not smooth, but at least the results are much stronger when everybody is actively involved and their voices are heard throughout the process. Next, please. Roisin.
Thanks so much, Kaku. And thanks everyone so much for joining today. My name is Roisin, and like Shanley said, I'm the Knowledge Mobilization Coordinator for the UBC Reproductive Infectious Diseases Program, also called RID. And at RID, we are a research team led by Dr. Deborah Money, focused on advancing reproductive infectious disease prevention, treatment, and clinical care. And we collaborate with teams locally, nationally, and globally, and we study topics including COVID in pregnancy, HIV in pregnancy, RSV, and the maternal infant microbiome. And one of the projects that we are working on, and something that I want to focus on today, is our work in syphilis in pregnancy. Next slide, please. So to give you a little bit of background, as you may know, syphilis is a sexually transmitted infection caused by bacteria. And syphilis testing is done just through a blood test, and it can be fully treated with antibiotics, most likely an injection of penicillin. But you can get it again after having treatment, and untreated syphilis can lead to more serious health concerns. And if someone is pregnant and they have syphilis, it can be passed to a baby in utero or during delivery, which is called congenital syphilis. And unfortunately, congenital syphilis can lead to stillbirth, neonatal death, or severe lifelong complications. And pregnant women and pregnant people can also be fully treated for syphilis, and congenital syphilis can be fully prevented if they are adequately treated before delivery. And in BC, the current guidelines are that people are routinely screened in the first prenatal visit, and then again at the time of delivery. Next slide, please. So we are experiencing really rapidly rising rates of syphilis in Canada. And this has been especially concerning for females of reproductive age, where we've seen a rate increase of 729% from 2017 to 2021. And the reason that we are concerned about this, of course, is because of pregnancy. And due to this rapid rise in infectious syphilis in females, we've also seen the rate of congenital syphilis in Canada increase by 1,271%. And as you can see from this graph here, rates have followed a similar trend in BC. So this shows the congenital syphilis reports from 1998 until 2024. And we were seeing almost no cases before this uptick in 2019. So in BC, we were a little bit behind the curve of Canada. Rates initially increased a lot in the prairies, but now BC has caught up to the trend. And so at RID, we really want to figure out why this is happening. And last year, our team responded to a CIHR grant call to kind of better understand the current trends and context of syphilis and pregnancy in Canada. And so one part of the project is collecting national public health assessment data, so information on all of the cases of syphilis in pregnancy, including those that led to congenital syphilis. And then another part of the project is doing integrated knowledge mobilization to share information with maternal care providers and the public and kind of anyone who could use it. Next slide, please. So far, we have collected data from 200 cases in BC from 2015 until the end of 2024. And we have found that maternal syphilis disproportionately impacts those who identify as Indigenous, those who use substances, those who have lived or living experience of mental health conditions, and those who experience unstable housing. And in this data, we have also found that 25% of cases had very limited prenatal care. So either none at all, or they had their first visit in the third trimester. And as I mentioned, prenatal care is so important because the routine screening that's done can get people in for treatment before delivery. And from our data, we can't, specifically say why this is, but we do know that our health system may feel unsafe for Indigenous folks and for folks who use substances. And we know that the lack of access to culturally safe prenatal care is a significant challenge. Next slide, please. So alongside data collection, we have worked to establish partnerships with organizations across BC involved in the syphilis response. And so this includes a national team that we pulled together, a working group of representatives across the health authorities, First Nations Health Authority, and groups within the BC CDC. And Nicole and Kaku both mentioned the different types of knowledge users a project might be hoping to engage, as well as the subtypes within these larger groups. So when we were engaging with providers, we had to think about kind of the many types of providers that would be involved in this care delivery cascade for syphilis and pregnancy. And so we engaged with specialists in infectious disease, in pediatrics, perinatal substance use, midwifery and doula care, Indigenous health and cultural safety, and pregnancy outreach and peer support. And at the onset of this work, we also established an Indigenous circle of obstetricians and public health nurses and kind of all kinds of perinatal professionals who are from Indigenous communities across BC, and they have guided and advised on our data interpretation and our knowledge mobilization. And they have been really instrumental in connecting us to other people and other groups in this space. Next slide, please. And so through our engagement with various groups, we have a few reflections here, which are that, as I said, lack of access to prenatal care is a significant challenge. The importance of prenatal care was perhaps de-emphasized during the pandemic as services went online and people were discouraged from seeing providers outside of, really urgent issues. We've heard that some providers are uncomfortable having conversations about sexual health and about syphilis. We've heard that providers and certainly the public are not aware of the rising rates in BC. And we have heard that there is a disconnect between public health and community-based health. Next slide, please. And so with these reflections, we laid out a few knowledge mobilization goals, which are to emphasize the importance of prenatal care and empower pregnant women and pregnant people to access prenatal care, to spread awareness about syphilis and pregnancy, and to develop resources to support communities at risk for syphilis. And I'll be sharing 2 examples of KT activities that we've done to reach these goals. Next slide. So the first example is a postcard-sized resource we created. Through the Indigenous Circle that I mentioned, we were connected with the doula team at the BC Association of Aboriginal Friendship Centers. And it's here that we kind of collaborated to develop our messaging and the style of the resource that would be meaningful. And this is kind of where the idea for developing this resource really began. And then through that connection, we also had the pleasure of being connected to an Indigenous artist who we ended up partnering with to bring this vision to life. And I'll talk a little bit about these points on the next slide. So this is our resource. We heard from partners that arts-based resources really resonate with their clients. And so we decided to make that kind of a central part of this resource. And as you can see from the front here, it doesn't actually reference syphilis at all, because we also wanted the resource to be accessible and to be something that someone might see themselves in and actually pick up. And the messaging, supporting a safe and healthy pregnancy and taking charge of your health is an act of strength, is messaging that we hope to be trauma-informed and coming from a strengths-based perspective. And I'll just pause so we can all look at the resource. Next slide, please. So the messaging on the back is very simple messaging, but kind of a culmination of the important messages we had been hearing. So syphilis infections are common and easy to diagnose and treat. Having syphilis when you're pregnant can have serious impacts on your baby. Getting tested is done with a simple blood test. Your prenatal healthcare provider will order a test for you, and you can request a syphilis test at any time. And then on the side there, getting tested and treated early in your pregnancy helps keep you and your baby safe. The QR code there is a Linktree hub that has resources on getting tested, accessing services, and various pregnancy-related resources. So you can kind of learn a little bit more that's in addition to the little postcard. Next slide, please. So in terms of dissemination, we distributed this digitally through direct emails as well as blogs and websites, newsletters, social media, and we also promoted it on a podcast. And these blogs and newsletters kind of came as a result of the partnerships that we had built and different groups offering to connect us with others in the space. We've also mailed them out to all 5 regional health authorities as well as FNHA. We heard many times throughout our engagement that physical copies are really valuable, especially in community. And so we wanted to make sure that this was a priority in our budget. And so we are also open to requests to print and ship them to clinics and organizations for free. And so we still do that. And we've also prioritized going to conferences and having exhibitor booths to engage with people who might find these useful. And so we attended the Provincial Perinatal Substance Use Conference, a gathering of the Indigenous patient navigators from across BC, which was an invite from the artists that we worked with. They were distributed at the Caretaking Earthside Doula and Birthkeeper Conference. And then most recently, we attended the BCA POP Annual Conference. And this is kind of important to note because at that first conference, the Provincial Perinatal Substance Use Conference, we ended up having a table just beside the BC Association of Pregnancy Outreach Programs, which is BCA POP. And we weren't previously in touch with them at all. And we just got to chatting with the director there and kind of became friends and built rapport. And now they've actually become one of our most meaningful partnerships, which has been amazing. And this leads me to the second part of the presentation, which is about the current KT project that we're focused on. And of course, the resource, we're still distributing it, but I also want to share a little bit about what we're doing now. Next slide, please. So as a quick reminder, this is what we had heard from our engagement. And what I really want to focus on now is that disconnect between public health and community-based health. Next slide. And then again, these are our quick KT objectives that we're still hoping to do in this project as well. Next slide. So through our engagement, we had heard time and again about the important role of peer support and outreach workers in reaching equity denied populations. And for context, peer support and outreach workers are typically non-medical staff, maybe with lived experience of similar situations, who provide emotional and social support as well as service navigation. And this role was really developed as a response to pervasive stigma, mistrust in the healthcare system, and a need for more accessible care. And peer support models are pretty well established, and they've been shown to be effective in mental health and substance use and HIV. And so peers were consistently being identified as potential agents of change to address the syphilis and pregnancy crisis, because they are the ones that are already walking alongside our pregnant populations. And so we are hoping to develop a toolkit with peers to share with their communities. And the idea is that this toolkit builds the capacity of peers to have conversations about syphilis with their clients and to empower and support them to engage in prenatal care. And the vision for the toolkit, we don't really know yet because we are in the early stages of our engagement, but it could be a PowerPoint with an accompanying script, maybe a handbook with some FAQs and suggested responses, different resources on talking about syphilis and anything else that's identified. And then peers could use this one-on-one with clients or in prenatal groups or at other events they're hosting. And something that I noted on the slide there, and that's really exciting, is that we were able to apply for funding in partnership with BCA POP to do this. Of course, TBD on getting the funding, but a formalized partnership in the form of a grant application is a huge success. Next slide, please. So to start this toolkit, we hired a peer research consultant because we knew that this was a little bit outside of our expertise as infectious disease researchers. But with her, I will be hosting 2 focus groups with people in peer roles who do support pregnant people, and we can gather kind of some more information that can inform these toolkits. And then we are hoping to invite the participants to join a peer advisory committee so they can continue providing feedback for the duration of the project. Next slide, please. So that was just a quick overview of what we were doing here at RID. And to wrap things up, I just wanted to share a few examples of our metrics of success. So of course, one big success is that we developed a public-facing resource that didn't previously exist. There was a gap in the existing resources and we went and created it. And now we can share that over 5,000 people have been reached online. We've mailed out 2,000 postcards. We've handed out 1,000 in person to people. And we can measure things like social media engagement and website and link tree usage. That's all super useful to knowing if we're reaching the people that we really want to. We can also see how many new partnerships and collaborations we've created. And so when I think about this, I can kind of see that we've created a web of connection that wasn't there previously. When I started this work, we were talking a lot about how the health authorities or public health are working in silos from one another. And I think one of the things that our team has done has been able to connect people in the space who should be working together and who previously weren't connected. And then finally, through this, we have identified a gap and developed a feasible action plan to address it. And we did recruit focus group participants. And so we know that we are able to reach the groups that we want to connect with, and that is a success. Next slide. So finally, I have some principles of engagement and lessons learned to share. The first thing I want to share is to keep an open mind. I said the initial grant plan is just a plan. Once we started, we knew that we kind of had to be open to the direction of the work and not stuck in our original plans. And I viewed my role kind of less as the expert, but more as just the coordinator of all of the expertise and lived experience that we had gathered. To seek the truth and recognize the gaps. And I say here, this is part of a justice-oriented approach. This topic has been somewhat difficult at times, and my team and I struggle a lot with the complexities and the social barriers that, we are not in a position to overcome with the scope of this project. But by sitting in the truth and the reality of the situation, we have been able to identify some gaps, and we've really tried to bring in the folks that are less represented in scientific research. And then being honest about the stage of the project and what we know and don't know has really helped our relationships grow a lot. It can be a little uncomfortable to sit in meetings and admit that you don't know where to go from here, but having that authenticity and having your partners play an equal role in the work is so important. Next slide. And then the last three are to be accountable. Bearing witness to lived experience requires relational accountability, and we really want to make sure our partners know that the things they are sharing with us will be action to the best of our abilities. I mentioned a lot to seek opportunities in person. I mentioned connecting with BCA Pop just from sitting next to one another at a conference. And I say here that the seeds of partnership can be planted just from one conversation. I really think that seeking out these opportunities and just seeing what happens can make so much of a difference. And then, like Kaku said, partnership takes time. All of this has been happening over a whole year, but our relationships are really what have led us to this work. And each connection has then connected us with someone else and another person. And this takes time. And these relationships are beneficial to this project, but also to the future of the RID program and talking about what's next and how we can mobilize these for other infectious diseases and pregnancy projects. And we have 1 minute left, so I'll hand it back to Nicole. And thanks so much for listening.
Yeah, I'm not sure that we have time for questions, but all of our contact information is up here. And we are more than happy to send out, I think, all of our resources. So if you're not subscribed to CRCnet, we'll send our slides and our links to resources so that you can all have them and do awesome KT work.
Thanks, everyone. And not sure, Nicole, if you saw that one question in the Q&A just about forwarding the KT templates and resources. So if you have any templates, it'd be great. You could forward those along the CRCnet. Thank you so much, everyone. What a wonderful presentation. You're all such great presenters, and it was very informative. So thank you so much for joining us today. Just a heads up for everyone joining the call that there won't be a lunch and learn in the month of August. Just understanding that lots of people are taking holidays and vacation with family and friends. So we will reconvene the Children's and Women's Clinical Research Lunch and Learn sessions in September in the fall. So thank you. Have a wonderful rest of your afternoon.